Good evening, all. Greetings and warm welcome to all medical cadres and healthcare professionals to this session. It is a pleasure to virtually stand before you today as we gather for this enlightening webinar on CPT 2024 updates conducted by Cigma Medical Carding Private Limited. First of all, let me introduce myself. I am Gayatri Madhu S, Senior SME of Cigma Medical Carding Academy. I will be your host for this session. Today, we are not just hosting a webinar, we are creating a virtual space for knowledge exchange and collaboration, and you are a vital part of our journey. It is my honor to welcome the training and development team of Cigma, and once again, hearty welcome to our students and cadres. Your presence adds richness to our collective learning experience, and we are excited to explore the CPT 2024 updates together. A kind notice for all the attendees, the CEU assured in our last webinar, ICD 2024 updates will be credited within 2 days. Also, for the collection of CEU of this webinar, a Google form will be shared towards the end of the session. Please enter your details correctly for submitting CEUs. Those who has attended the session at least 90 minutes will be eligible for the CEUs. Once again, I would like to stress on the information that do not share your personal details, member ID or email ID in the chat. Use the Google Form link to submit the details, which will be shared at the end of the session. So today, our presenter, Dr. Jaydevi K.S., is a BHMS graduate with a CPC as well as CCI certification in medical coding. She has been a successful homeopathic practitioner since 2005. Her expertise in health information management span around 17 years. She started as a medical transcription trainer and has also worked as medical analyst and medical editor with esteemed organizations. She has been a part of Cigma training team since 2021. She is a senior subject expert handling both US and Australian coding. So before I welcome Dr. Jaydevi for the session, I have a few instructions for the listeners. During the session, your audio will be muted and the chat option is currently unavailable. Please do not scribble on the screen. There will be a Q&A session after the presentation for the clarification of any doubts. Now I welcome Dr. Jaydevi for the session.
Thank you, Gayatri, and a warm welcome to everyone. I'm Dr. Jaydevi. I'm here to present CPT 2024 updations. So let's look into the details. American Medical Association regulates and maintains CPT Professional 2024 publication. There is a total of 11,163 codes in 2024 CPT publication. That's the total number of codes in the new publication. Now let's look into the chapters in CPT, the code ranges. Evaluation and Management, 99201 to 99499. Anesthesia, 00100 01999. 99100 99140. Yes. Now we'll go and look into the numerical data of 2024 CPT changes. Total additions are 230, deletions are 49, revisions are 70, and the total changes are 349. Let's go into a glimpse of overall chapter-wise changes. Now, chapter-wise changes, evaluation and management, the code range 99202 to 99499. The additions are 1 new code has been added, 10 revisions have been made. Am I audible?
Yes.
Yes, ma'am.
Okay.
Yes, ma'am.
Okay, fine. Anesthesia codes, there is no change in anesthesia codes. Integumentary system also, there's no change. Female genital system, there is one new code added. There's no revisions or deletions. Nervous system, 6 new codes are added, 4 codes are being revised, and there is no deletions. There is no deletions. In eye and ocular adnexa, one new code is added. Auditory system, there is no change. Radiology, there are new 5 codes added, 1 deleted. Pathology and laboratory section, 75 new codes are added, 25 are revised, and 15 codes are, pathology, 15 codes are deleted. Medicine chapter, 43 new codes are added, 12 are revised, there's no deletions. Category 3 codes also, 82 new additions, 13 revisions, and 32 deletions. Administrative multi-analyte assays with algorithmic analysis. 1 addition is made and 1 deletion is made. A total of 230 additions, 70 revisions, and 49 deletions. Now we go into the summary of changes in 2024. New and revised codes in E-Anthem session and new and revised guidelines also introduced in E-Anthem. New and revised code in the surgery section, new and revised code in the PLA codes, new and revised codes in the medicine section, revision of various sections of CPT that contains unlisted service codes, and new codes and revised codes in the category 3. Let's have a look into the chapter-wise updations of 2024 CPT. First, into the evaluation and management. So there is a new code added in the evaluation and management section. There's no deletions. 10 codes have been revised. The new code is an add-on code 99459. It's regarding a pelvic examination. Only this code that captures the direct practice expenses associated with performing a female pelvic exam. That's regarding when a gynecologist gives an E&M service. If the doctor had to examine the female genital region or had to use any gynecological equipments, the expenses met by this code, that is 99459. This can be coded along with the E&M service. Now we'll move on to the revised codes in the OP services, 992022 to 99205 and 99212 to 99215. To align with the format of other E&M codes, the time range from office or other outpatient visit codes 99202 to 99205 and 99212 to 99215 has been removed. That is, in earlier 2023, these codes had a range of time, but this is removed now, and now the code selection is based on threshold time. Now, what is threshold time? Threshold time is the minimum time of service requirement that should be met or exceeded by a healthcare provider for reporting a code. Now, looking into the OP code revisions, 99202 OP code, new patient. Earlier, it was 15 to 29 minutes. It's changed to 15 minutes now. 15 minutes threshold time. 99203 OP new patient visit. The time range from 30 to 44 minutes in 2023 is changed to 30 minutes threshold time. 99204 OP new patient visit. 2023, the time range was 45 to 59 minutes. Now, the time is changed to threshold time of 45 minutes. 99205 OP new patient visit. The time range was 60 to 74 minutes in 2023, but now it's changed to 60 minutes threshold time. In OP established patient codes, that is 99212 to 215 also, there has been change. In 99212, earlier it was 10 to 19 minutes. This was changed to 10 minutes threshold time. 99213 OP established patient. Range of time was 20 to 29 minutes. This was changed to 20 minutes. 99214 OP established patient. The time range was 30 to 39 minutes. Now it is changed to a threshold time of 30 minutes. 99215 OP established patient. The time range was 40 to 54 minutes and it's changed to 40 minutes now. 40 minutes threshold time. Now into the revised codes of nursing facility services. 99306 and 99308. The change in threshold time for level 1 codes of initial care and subsequent care codes per day. Now the initial care nursing facility code 99306. Earlier, the time was 45 minutes, which is changed to 50 minutes in 2024 CPT edition. Subsequent care nursing facility code 99308. Earlier it was 15 minutes. This was changed to 20 minutes in this new edition. Now into the new and revised guidelines of the ENDM. The first guideline is regarding the split or shared visit. Second one is regarding the multiple E&M encounters on the same date of service in the same setting as well as in the different setting. Discharge services and other service settings. Emergency department and service in other setting. Transitions between office and other services. And reporting instruction for admission and discharge on the same day. Now, split or shared visits. Sometimes a service may be shared by more than one physician. Physicians or other qualified healthcare providers may act as a team in providing care working together during a single E&M visit. Code for the service is determined by split or shared visit guideline. So what is the guideline for split or shared visit? Code selection is based when the code selection is based on time. The service is reported for a physician who performed the majority or the substantial portion of the service time, face-to-face or non-face-to-face. Now, if the code selection is based on MDM, then service reported for the physician who performed the substantive part of the MDM should be given the access to the code. Now, what is a substantive portion in MDM? As you know, MDM has three components. That is, number of diagnoses, data review, as well as risk of management. The substantive portion is determined based on performance of 2 out of 3 elements of MDM. Physician or qualified healthcare provider who made or approved the management plan as for the number and complexity of the problem, or the physician or qualified healthcare provider who takes the responsibility of the plan with its inherent risk of complication and or morbidity or mortality of the patient management. The amount and or complexity of data or tests to be reviewed and analyzed do not have to be personally ordered or reviewed by the physician, but should be interpreted or discussed as a part of management plan by the physician. Now, multiple E&M services on the same day. When considering multiple services on same setting on a calendar date based on services, only one single service is reported. When considering different levels of MDMs during the multiple visits in the same setting, so multiple visits in same setting with different levels of MDM on a calendar date, one can take the aggregate of MDM for code selection. When using time as criteria for code selection in multiple visits in the same sitting on a calendar date, then sum of the total time over the course of the treatment is in a day is taken for selecting code. Now into the next session, multiple E&M service on the same day, different setting. A patient may receive more than one E&M service on a calendar date in IP and observation care or nursing facility. Now code separately based on the time specifically spent on each setting since the settings are different. Example, if a patient gets an IP service and is transferred to a nursing facility, you have to code discharge service of IP as well as the initial care service of the nursing facility. Prolonged service are also coded separately based on the same allocation in relation to the primary service. Intra-facility transfer is not considered a separate step. Now, multiple E&M service on the same day. Emergency department visit and other settings, that's IP or observation. As you know, in 2023, a new guideline was added where a patient, if given both IP and OP service on a same day, you have to code both with a 25 modifier to the OP code. This guideline is prevailing still. It's still prevalent. But there's a change. If a physician provides initial service in emergency department as well as subsequent service in any other setting like inpatient or observation care, and if the emergency service is not reported, then the physician can report E&M service, inpatient, observation care with the total time provided. Time provided in the emergency department plus the time for subsequent inpatient or observation care can be given as a criteria for selection of codes. Now into the discharge service, and service is the same facility on the same calendar date. If a patient is discharged from a facility and readmitted to the same facility on the same calendar date, so instead of providing the initial and discharge service code the subsequent service. Now discharge service and services in a different facility. If a patient is discharged from one facility and admitted into another facility on the same calendar date, since the settings are different, you have to code both the services. Transition between office and other services. If a patient is seen in two settings and only one service is reported, the total time on the date of the encounter or the MDM aggregate can be used for selection of codes. Also, prolonged service may be reported based on the primary service reported irrespective of where the extended service was provided. Now, admission and discharge on the same date. 99234 to 99236. Let's compare the change of codes from 2023 to 2024. These codes are used for admission and discharge services on the same date of service. These codes were reported for admission and discharge service within calendar date of 24 hours in 2023, while in 2024, the codes are reported only when the admission and discharge services are within a time period of 8 hours or more than 8 hours within a calendar date. So let's have a look. So if a patient is admitted and discharged on a same calendar date as initial hospital inpatient or observation care service, and the total length of stay is less than 8 hours, then you can report only the inpatient initial codes, that is 99221, 99222, and 99223. If the patient is admitted and discharged on the same calendar date as initial hospital inpatient or observation care service, and the total length of stay is 8 or more hours, then you can use this code 99234, 235, and 236. Again, if a patient is admitted and discharged on a different calendar date as initial hospital inpatient or observation care service, and the length of hospital stay is less than 8 hours, then you cannot give the discharge codes. You can give only the inpatient initial service code, that is 99221, 99222, and 99223. If a patient is admitted and discharged on different calendar date as initial hospital inpatient or observation care service, then if the length of stay is 8 or more hours, then you can code both the inpatient service as well as the discharge service, that is 99221, 99222, 99223, and 99238 and 239. Now by this we have ended the E&M session, and we'll go and move on to the next session. There's no change in the anesthesia section, no additions, revisions, or deletions. Integumentary system, so there's no change. There is no addition, deletions, or revisions. Moving into the musculoskeletal system, there are 4 new codes added and 6 codes are revised. The added codes. New codes have been added under the instrumentation section in musculoskeletal system. The codes 22836 to 22838 includes anterior thoracic vertebral body tethering and revision procedure. Now, what is tethering? Tethering is a process by which a spinal curvature is corrected either by laminectomy or by cord ligation techniques or attachment techniques. This is mostly done at the base of the spine. Now coming to the next code is 27278 arthrodesis code. This is a new code added in 2024 CPT edition. This is arthrodesis without placement of transfixation device. A similar code was present in 2023 edition, that is 27278, but the difference is that it is with placement of transfixation device. Now moving on to the revised codes. 28292 to 28299 includes correction of hallux valgus. What is hallux valgus? It is a lateral deviation of the big toe. Usually, the inflammation caused in the first metatarsophlangeal joint, that is in the toes. It's otherwise called bunion. In the range of codes, earlier it was the bunionectomy was placed inside a square bracket, but now it is replaced with bunionectomy. That is, bunionectomy is intended, and this correction is made to clarify the intended use of the scope. Moving on to the respiratory system. 2 new codes have been added. There is no deletions or revisions. These 2 new codes comes under the endoscopy section of respiratory system, the posterior nasal nerves, posterior nasal nerve dissection by 2 methods. So for 31242 is by using endoscopy, the posterior nasal nerve dissection by radiofrequency ablation, and 31243 is posterior nasal nerve dissection by cryoablation. Moving on to the cardiovascular system. 8 new codes have been added to the cardiovascular system. There is no revisions or deletions. Phrenic nerve stimulation system. New codes have been added under the heading Phrenic nerve stimulation system in cardiovascular system. Codes 33276 to 33277 pertains to the insertion, while 33278 to 33780 pertains to removal, and 33281 for repositioning of phrenic nerve stimulator. 33287 to 33288 are removal and replacement codes of phrenic nerve stimulators. So what is phrenic nerve? What is the supply of phrenic nerve? Phrenic nerves are the nerves that innervates the diaphragm, and the stimulation of phrenic nerve will help in the contraction of the diaphragm, which increases the hyperfunction of the thoracic cavity organs. Now moving on to the next session. Digestive system. There is no changes at all in the digestive system. Genitourinary and female genital system. 2 new codes have been added. There's no revisions or deletions. In the urinary system, new code added is 52284. It's mechanical urethral dilatation and urethral therapeutic drug delivery through a drug-coated balloon catheter. Cystourethropy with mechanical urethral dilatation and urethral therapeutic drug delivery through a drug-coated balloon catheter for urethral stricture or stenosis in males. Female genital system, a new code added is 58580. It's a ablation of uterine fibroid, but the method is transcervical. There is a similar code in 2023 chapter, the same chapter, that is 58674, but the procedure is done by laparoscopic method. In the male reproductive system, there is no change, no additions, deletions, or revisions. Moving on to the nervous system, 6 new codes are added, no revisions or deletions. Deep brain stimulators or DBS. New codes are added in the section of neurostimulators for deep brain stimulators. The codes 61889 to 61891 are regarding insertion, revision, or replacement, removal of skull-mounted cranial neurostimulator. And codes 64596 to 64598 are regarding insertion or replacement and revision or removal of electrode array of peripheral nerve stimulator. The codes that has been added and changed in the gastric neurostimulator, peripheral or gastric neurostimulator 64590. Earlier, direct or inductive coupling word was there in 2023, but in 2024, insertion or replacement of peripheral or gastric neurostimulator pulse generator receiver, you can directly go into requiring pocket creation and connection between electrode array and pulse generator receiver. Direct or inductive coupling is removed. 64595, again revision or removal of peripheral, a word sacral region is added, and also with detachable connection to electrode array is being added into this code. Revised codes added in the section of spinal neurostimulator pulse generator 63685. 63685, insertion or replacement of spinal neurostimulator pulse generator or receiver. Direct or inductive coupling is deleted, requiring pocket creation and connection between electrode array and pulse generator or receiver. Now 63688, revision or removal of implanted spinal neurostimulator pulse generator or receiver with detachable connection to the electrode array is added. In eye and ocular adnexa, one new code is being added, 67516. It's a suprachoroidal space injection of pharmacological agent. So what is a choroidal space? Choroidal space is a space between the choroid and sclera, which comprises the posterior segment of the eye. So this is a suprachoroidal space injection of pharmacological agent. In auditory system, there is no change at all. There's no addition, deletion, or revision. Thank you. Moving on to the radiology section. 5 new codes are added into the radiology section, no revisions, but one code is deleted, 74710. This code is deleted due to inconsistent usage. Actually, this was a code related to pelvimetry with or without placement of placental localization. Placement with placental localization, this is deleted. New code added in the section of heart in the radiology, 75580. Non-invasive non-invasive estimate of coronary fractional flow reserve, FFR, derived from augmentative software analysis of the dataset from a coronary computed tomography angiography with interpretation and report by a physician or other qualified healthcare provider. FFR, or fractional flow reserve, is a comparative study between the blood flow before and after the clot. Codes under other procedure sections in the radiology chapter, 76984, it's intraoperative thoracic aorta ultrasound. It's a diagnostic procedure. New codes added to other procedure sections in intraoperative cardiac ultrasound, 76987 to 76989. It's epicardial cardiac ultrasound. Intraoperative epicardial cardiac ultrasound for congenital heart disease corresponding to placement, image acquisition, interpretation, and reporting. Moving on to the next portion, pathology and laboratory section. 75 new codes are added, 25 codes are revised, and 15 codes are deleted. (81457) to 81459. It's solid organ neoplasm, interrogation for sequence variants, 81462 to 81464. Genomic sequence analysis pattern for cell-free nucleic acid interrogation and analysis. 81517 is liver disease analysis of 3 biomarkers, that is HA, high hyaluronic acid, P3NP, that is procollagen 3 amino terminal peptide, TIMP1, that is tissue inhibitor of metalloproteinase. 82166, that is anti-Mullerian hormone chemistry. It's regarding the growth differentiation folliculogenesis. This is usually done with pregnancy or PCOS cases. 86041 to 86043, acetylcholine receptor binding antibody, blocking antibody, and nodulating antibody codes. 86366 are MuSK antibody, in the immunological section, MuSK antibody. 87523. It's added in the microbiology section regarding hepatitis D delta. 87593. A new code added in the microbiology section for orthopox virus. Several PLA codes and preparatory laboratory analysis codes have been added in the pathology and laboratory chapters also. Moving on to the revised codes in the pathology. 81171 to 81172 is regarding gene analysis. Again, 81243 to 81244 also dealing with gene analysis. 81403 to 81407 is DNA sequence analysis revised codes. 81445, 81449, 81450, 81459, 814455 and 81456 are all coming under genome sequence analysis, and some new codes have been revised. Now moving on to the medicine section. 43 added codes are there, new codes. 43 new codes, 12 revised codes. There's no deletions at all. 90380, 90381 are RSV codes, that is respiratory syncytial virus antibody vaccine codes. 91312 to 91317 is COVID-19 immunization codes. 90589, the chikungunya virus code. 90679, 90683, RSV vaccine codes pre-F. 90611 is smallpox and monkeypox vaccine. 90622 is vaccinia virus vaccine, while 90623 is meningococcal pentavalent vaccine. Please don't scribble. Codes from 93584 to 96588 are new codes found in cardiac catheterization for venography done for congenital heart disease. These codes are add-on codes which can be added with right and left heart catheterization procedures for congenital heart disease. New codes, add-on codes 96547 and 96548 are added in the medicine chapter under this section. Other injection and infusion services for intraoperative hyperthermic intraperitoneal chemotherapy procedure, that is HIPEC procedure. Now, what is HIPEC procedure? This includes intraoperative perfusion of a heated chemotherapy agent into the abdominal cavity through catheters. These are add-on codes which can be added with abdominal surgeries like splenectomy, gastrectomy, total abdominal hysterectomy, and etc. 97037 is a new code added in the modality session. The constant attendance requiring direct patient contact, lower level laser therapy, LLLT, to treat post-operative pain reduction. 92972 is percutaneous transluminal coronary lithotripsy. It's a new code added under the coronary therapeutic procedures and service, which can be added along with the PTCA procedures. 93150 to 93153 for activation, interrogation, and programming of phrenic nerve stimulation. So we have already discussed new codes in the cardiovascular system regarding the implantation, then revision and reactivation and replacement of this phrenic nerve stimulators. Thus, the activation, interrogation, programming of these stimulation system is added in this section. Coming on to the revised codes. 96446. It's a chemotherapy into peritoneal cavity via implanted catheter. Earlier in 2023, the same code was there, but instead of implanted, it was induced. 96920 to 96922. It's Excimer laser treatment for psoriasis. 2023, the word Excimer was not used. It's just laser treatment for inflammatory condition of skin or infectious condition of skin. And this is precise code for Excimer laser treatment for psoriasis. Now, what is Excimer? Excimer means it's a laser that uses ultraviolet rays, B rays, to treat affected skin diseases. I mean, like areas of skin. Another revised code is 0154 to 154T, and other 8 codes are also revised here. 97550 and 97552 are added as a new section in the caregiver training with all the patient present for the individual and multiple sets of caregivers. So, what is caregiver training? That is a direct, skilled intervention for the caregivers to provide strategies, techniques to equip them with knowledge and skills to assist the patient who are living with the functional deficits. And also, new codes added are given below. Now, a quick look into the vaccination codes added. Immunization codes of COVID-19 has been synchronized, and RSV immunization codes are added. New codes, COVID-19 codes are 91318 to 91322. These are provisional codes. 91318 to 91322 are provisional codes. are monovalent immunization codes provided by Pfizer and Moderna for COVID-19. 90480 is also approved. You can move on to the last section, the changes in category 3 codes, new codes, revisions, also introduce various guidelines for new emerging technologies. That's all regarding the session. Thank you so much. If you have any queries, you can utilize this time. Thank you so much. So split or shared visit, if two or more doctors have provided services for a single patient, that is a shared visit, shared service, then the doctor or the physician who provided the substantial portion or the more than 50% of the service is eligible for giving the service bill. So if the code selection is based on the time, then you have to see which physician has provided the substantial portion of the time based on the MDM. Based on the MDM, you know the MDM has 3 components, and you can go into the substantial portion based on the performance of 2 out of 3 elements. And physician or qualified healthcare provider may give this service code when he has approved the management plan. Both physician has provided service. Still, if one physician has approved the management plan, or the physician who takes the responsibility of the plan and is responsible for the risk of complication, morbidity, mortality regarding the patient management, he can give the service code. Also, regarding the amount and complexity of data in this thing, the doctor may not directly order this test or review it, but actually the result must be taken into consideration for interpreting or discussing. Must be have discussed as a part of management plan by the physician. So a substantial portion is determined based on the substantial service that is provided by the physician.
Now we wind up the session. So thank you, Chetu Miss, and all listeners for attending this session. Thank you.
Thank you, everyone.